Hey everybody, thanks for joining this afternoon. Another talk in our lecture series. We've got Dr. Sara Tabtabai joining us. Dr. Tabtabai is our newest member of the heart failure group at Yale. I'm very excited that she agreed to give this really interesting lecture on the cross-section of a variety of comorbidities that we need to take into account with patients that have heart failure, and thinking more broadly about heart failure management with these patients. So, Sara, thanks again for agreeing to do this talk, and I'm interested to see what you have to share.
All right, thanks everyone for having me. So I'm going to talk about, as Michael mentioned, lifestyle, comorbidities, and heart failure. Big topic for 30 minutes, so we're going to kind of do a big overview and try to hit on some high points of each of the lifestyle and then comorbidities that we'll talk about. So here's the pre-survey QR code. I'll give you guys a minute to grab that. And then I'll move on here. So just to briefly go over our learning objective. So the objective is to know which lifestyle choices and comorbidities, example, including obstructive sleep apnea, depression, anemia, diabetes, hypertension, renal failure, contribute to the development of or clinical instability of patients with heart failure. So with that in mind, a brief overview here. We'll start a little bit with talking about lifestyle measures, move on to the comorbidities you see here. So again, in 30 minutes, we're going to go over kind of the high points: anemia, obstructive sleep apnea, diabetes, hypertension, depression, and renal failure. So just to briefly introduce, as we know from taking care of these patients, multimorbidity is very common in heart failure. So more than 85% of your patients with heart failure have greater than or equal to 2 additional chronic conditions that they're trying to manage at the same time. Most of what I'm going to talk about today is going to come from a couple of main documents. I think especially when you're sort of working on studying for the boards, really going back to what the guidelines say is very helpful. So I try to bring a lot of this information from some of the guidelines. You'll see some of it's pretty sparse in many of these areas, but this is one of the main guideline documents that I'll take information from. So it's a 2022 AHA, ACC, HFSA guideline for the management of heart failure. And that's in circulation. And then we'll have some points from the 2023 ACC expert consensus decision pathway on the management of heart failure with preserved ejection fraction. So those are sort of 2 good documents to go back towards that do talk about comorbidity management and heart failure. So just briefly, here's an overview from that 2022 guidelines chart that tells us the most common co-occurring chronic conditions among Medicare beneficiaries with heart failure. Along the left-hand panel here, you'll see in those folks over 65. Hypertension is high on that list. So of the things that we're going to talk about, hypertension is high on that list: anemia, diabetes, CKD. And then here for beneficiaries under 65 on the right-hand panel, hypertension again is number 1, diabetes, anemia, CKD, depression. So very common that we're going to see many of these comorbidities along with others in our patients with heart failure. And here's just a pictorial summary again from that 2022 document that talks about many of the comorbidities that we commonly are faced with in our management of heart failure patients. And again, the ones we'll focus on here, in addition to optimizing GDMT, we'll talk about those that have level of evidence 1, patients with heart failure and hypertension, patients with heart failure and type 2 diabetes, iron deficiency, and sleep apnea. So let's get a little bit into it. So this document is also a very nice one. It's from Dr. Argawal. It's looking at lifestyle modifications for preventing and treating heart failure. And it's a very nice summary of what evidence and what degree of evidence is out there. So here's a summary pictorial just looking at the lifestyle issues that are associated with increased risk of heart failure. So you can see across the top here, poor quality diet, low physical activity and low fitness, and emotional stress. These can lead to inflammation, oxidative stress, and sympathetic activation, which can result in many of those comorbidities we saw: hypertension, diabetes, dyslipidemia, and sleep-disordered breathing. These can affect cardiac remodeling and atherosclerosis and can end up resulting in or contributing to heart failure. So if we see along the right-hand side here, lifestyle approaches to reducing the risk of developing heart failure, there is some evidence for healthy diet, increased exercise or leisure activity, and mind-body training. As far as lifestyle interventions go and looking sort of at the guidelines and the evidence that's out there, the most evidence for benefit in patients that already have a diagnosis of heart failure is available for the benefit of exercise training. As far as the most evidence for preventing development of heart failure, there is evidence for achieving and maintaining high levels of fitness and maintenance of normal body weight. So that's the general summary from that lifestyle paper we talked about. And then if we look at those 2022 guidelines, really what they mention is this one bullet here: in the general population, healthy lifestyle habits such as regular physical activity, maintaining normal weight, healthy dietary patterns, and avoiding smoking are helpful to reduce future risk of heart failure. So that's really looking at the development of risk. So taking away from this, that exercise training has benefit for patients that have a diagnosis of heart failure, and then for preventing, really focusing on some of these lifestyle measures, and highlighted in those are normal body weight and high level of fitness. This is a nice chart from that same document, the lifestyle document, that talks about transmitting some of these recommendations into clinical practice. So if you look along the left-hand panel, some of these things that we mentioned, so specifically weight loss, tells you here what the level of evidence is, and then some suggestions on how to sort of incorporate that into practice. For example, the exercise piece that we looked at, so here, exercise, low, moderate, or high, there's strong level of evidence in all stages of heart failure. And then as far as incorporating into practice and heart failure patients, starting with stationary bicycle, low level and no incline treadmill, and pool walking is a good start. So I'll usually talk to my patients both at risk for heart failure and that have heart failure about walking, because that's usually the most easily accessible to patients. Just start walking 30 minutes a day. There's really a fair amount of evidence there that that's going to help heart failure patients feel better and decrease the risk of developing heart failure in patients that are at risk. So moving on to anemia, there's a lot of data here looking at iron deficiency anemia in heart failure. So I'm just going to give some of the highlights and then alert you towards a paper that I think is lovely kind of overview. So when we're talking about anemia, specifically, a lot of the data is with iron deficiency in heart failure. So iron deficiency, independent of anemia or not, so regardless of sort of what the hemoglobin hematocrit is clinically relevant comorbidity that independently predicts prognosis in heart failure. So iron deficiency is very important in heart failure patients. About 50% of symptomatic heart failure patients are iron deficient. And in those patients, it's associated with worse functional capacity, decreased quality of life, and increased mortality. So it's a very important comorbidity for us to pay attention to. So this is coming from a summary written by an old mentor of mine, Dr. Lewis, Iron Deficiency and Heart Failure, a scientific statement from the Heart Failure Society of America, and that's here along the bottom panel. And this is published in 2023. Lots of information in this document that you can look at, but kind of talks about the levels of ferritin across the sort of A panel here across the top, and levels of TSAT percentage that you would be tuning into for your patients. So a ferritin less than 15 is the WHO and CDC definition of iron deficiency. Less than 30 is commonly considered the abnormal range for ferritin, and it goes along this spectrum. And then, as we know, in some patients, ferritin over 500 can be seen, and that would trigger you to think of iron overload or inflammatory conditions. T saturation less than 20% on your iron panel labs is going to be the threshold for iron deficiency. And then again, along the other end of the spectrum, TSAT greater than 50% is where we consider iron overload and stop IV iron repletion. Along the B panel here, I just want to highlight that ferritin less than 100 or a ferritin level 100 to 299 with a TSAT less than 20% is the most common definition of iron deficiency in heart failure guidelines and HF clinical trials. So that's usually what I will check in patients to understand if they are iron deficient. And again, that's essentially independent of hemoglobin levels. And this is the most common diagnosis. Along C panel here is the prevalence of iron deficiency by guideline criteria. So if you look up across the bottom of this graph, heart failure with reduced DF, 50 to 61%, depending on the trial, of patients with HFrEF will have iron deficiency. In mid-range EF, also very prevalent in the 60% range, and then in HFpEF, if anything, more prevalent. So there's lots of reason to screen patients. When we think about why iron deficiency is so important in heart failure patients, this panel is helpful again from the same Greg Lewis paper. Along the left-hand side, there's erythropoietic effects of iron deficiency that result in decreased oxygen delivery, which again is a direct component of the calculation for maximum oxygen consumption and can decrease the oxygen content in the arterial blood and decrease the peak oxygen consumption. There's extra erythropoietic effects, of which there are many. When we have iron deficiency, there can be decreased myoglobin, decreased aerobic enzymes, and decreased myocardial iron content, which all can result, again, in affecting these other measures of the oxygen consumption pathway. So we get less oxygen utilization and decreased LV function when we have lower myocardial iron content. So that's a helpful way to put into understanding as to why this is so important. And then this panel is actually very interesting. So this is a graph that looks at the baseline sort of components of our guideline-directed medical therapy pillars of treatment for heart failure. Along the bottom panel, you can see beta blockers, SGLT2, ACE inhibitor, ARNI, MRA. And then all the way to the right here, we see IV iron. And this is showing us the weighted average % change in exercise capacity with any of these treatments. And you can see IV iron has been shown across 6 studies to have very significant and higher improvement compared to those other therapies in improving exercise capacity. So it's a very important measure to identify and treat. As far as treatment and what the guidelines say about anemia and iron deficiency, so the ACC, AHA, and HFSA guidelines endorse routine evaluation of anemia and heart failure. And you can see down here, this panel is from those guidelines. So there's level of evidence 2A that in patients with HFrEF and iron deficiency with or without anemia, IV iron replacement is reasonable to improve functional status and quality of life. And it's really only IV iron. There's been a lot of history in the literature of looking at oral iron repletion, and the data is not supportive that oral iron has the same benefit. So it really should be IV iron replacement. There has also been data that erythropoietin stimulating agents should not be used in heart failure and that can actually cause harm. So those are level 3 evidence, but IV iron is level 2A. The European Society of Cardiology also has a class of recommendation 1, level of evidence C, for periodic screening for anemia and iron deficiency in heart failure. So obstructive sleep apnea, we'll briefly go over this as well. So in patients with heart failure, you always want to think about obstructive sleep apnea as being a possible comorbidity. Daytime sleepiness, which is something that we often think about in many of our medicine patients as being a trigger for thinking about screening for obstructive sleep apnea. It may not reflect the degree of underlying sleep disordered breathing in heart failure patients. So I would say I tend to have an extremely low threshold to screen all of my heart failure patients for sleep apnea. Certainly all of my HFrEF patients, I will send for sleep study screening. And for most of my HFpEF patients, because they do tend to have the common other findings like obesity that may be coexistent with sleep apnea. So I have a very low threshold. I order a lot of sleep studies. In patients with heart failure and central sleep apnea, as you can hear in the second bullet, continuous positive airway pressure is associated with better sleep quality and nocturnal oxygen. It has not been shown to affect survival. And then in patients with HFrEF and sleep-disordered breathing, there's meta-analysis of randomized controlled trials that show positive airway pressure results in moderate reduction in BNP improvement in blood pressure, and LVEF. And anecdotally, I do see here that I do think it leads to responsiveness to diuretics. So we'll see that sometimes patients admitted with volume overload, when they're adherent to their sleep apnea, to their CPAP machine, they tend to have better response to diuretics. But there's not a lot of data supporting that. But I think there's lots of reasons to think about screening patients for sleep apnea. Adaptive servoventilation has shown increased mortality in 2 randomized controlled trials involving patients with HFrEF and central sleep apnea, so that is not recommended. It's really just the positive pressure ventilation. And in summary, what the guidelines tell us is that in the management of sleep disorders, patients with heart failure and a suspicion of sleep disordered breathing, again, low threshold for the suspicion of sleep disordered breathing, a formal sleep assessment should be done or is reasonable to confirm the diagnosis and differentiate between obstructive and central sleep apnea. And then in patients with heart failure and obstructive sleep apnea, continuous positive airway pressure can be reasonable to improve sleep quality and decrease daytime sleepiness. There is that harm, and this is in the guidelines, that in patients with New York Heart Association 2 to 4, HFrEF, and central sleep apnea, adaptive servoventilation can cause harm. So we're really looking at positive pressure ventilation. Diabetes, let's see how we're doing on time. So for diabetes, the American Diabetic Association recommends the use of SGLT2 inhibitors as first-line agent for the treatment of hyperglycemia in patients with diabetes and heart failure, or those that are at high risk for heart failure. So new on the scene with heart failure treatment in general, but very much so in those that have diabetes. Think about SGLT2s as being sort of your first-line agent. They should be, SGLT2 inhibitors are the first class of glucose-lowering agents approved by the FDA for the treatment of HFrEF. And the mechanism is not fully understood, but it's really thought to be due to the glucosuric effect. And HFrEF specifically, empagliflozin showed reduced risk reduction of all-cause death, CV death, and hospitalization for heart failure and renal outcomes. So, and this is a summary from that heart failure with preserved EF expert consensus decision pathway and management of HFpEF in 2023. This is a very nice summary slide or summary table on HFpEF comorbidities. And you'll see here type 2 diabetes. Really, this summarizes that SGLT2 inhibitors are the first line of therapy. We should be targeting to get the hemoglobin A1C less than 7 to 7.5%. And the general 2022 guidelines for heart failure, patients with heart failure and type 2 diabetes, the use of SGLT2 inhibitors recommended for the management of hyperglycemia and to reduce HFrEF-related morbidity and mortality. So in our patients with heart failure and diabetes, make sure they're on an SGLT2 inhibitor. And that's sort of the takeaway point from these guidelines. Hypertension. So there's not a ton of trials that assess the impact of global blood pressure reduction on outcomes in patients with HFrEF and hypertension. I would say that we don't really know the optimal blood pressure goal and whether or not it's different in patients that have HFrEF or not, and the optimal antihypertensive regimen. But in general, when in my patients with HFrEF, reduced ejection fraction, I see elevated blood pressure as sort of an opportunity to make sure that their guideline-directed medical therapy agents are fully optimized. So I try to get their blood pressure actually as low as tolerated, and really utilize that elevated blood pressure to maximize all of their GDMT agents and get to maximum dose. So oftentimes that will mean patients may come to you on medications that are not part of the 4 pillars of the GDMT, like they might be on amlodipine for hypertension. I stop that and then utilize all of that blood pressure room that we have to get them on ARNIs and all of the other sort of guideline-directed medical therapy, maximize the beta blocker, et cetera. In patients with HFpEF, there's, I'll show you in the next slide, some summary from the guidelines that ACE inhibitors, ARB, MRA, and possibly ARNI may be first-line agents, and that's because there's a lot of use in HFpEF trials. So in the management of hypertension in patients with heart failure, you'll see here level of evidence or class recommendation 1 here in patients with HFrEF and hypertension, up titration to GDMT to maximally tolerated target dose is recommended. You'll see there's no blood pressure number here specifically, and in my practice, it's just kind of the lower the better, lowest as tolerated. And I really take that opportunity to get the GDMT maximized. In patients with HFpEF and hypertension, in this panel here, again, level of evidence or class recommendation 1, They should have medication titrated to obtain blood pressure targets in accordance with published clinical practice guidelines to prevent morbidity. And looking a little closer here, just zooming in on that heart failure preserved EF schematic that we saw, specifically looking at hypertension, blood pressure less than 130 over 80 millimeters. Unless the patient has symptomatic orthostasis, this should be our goal. And we get there by utilizing the diuretic agent they're on, ARNI or ARB, and MRA. And when necessary or appropriate, we evaluate for secondary causes. And that's sort of the summary of the recommendations for hypertension and HFpEF. Depression. So we have a few minutes left. I think depression is so interesting, the data that's out there with heart failure. So depression and heart failure, up to 30% of heart failure patients suffer from a diagnosis of depression, and even more than that have depressive symptoms, but maybe not a diagnosis of depression. When a patient has heart failure and depression, they have worse quality of life and worse clinical outcomes. That's been shown. The current heart failure guidelines do recommend to screen heart failure patients for depression. And depression actually increases the risk of incident heart failure and correlates with the severity of symptoms. So if you have heart failure, you're more likely to develop depression. And if you have depression, you're more likely to develop heart failure. And it's similar in patients with heart failure with that increased risk of depression. The findings are similar in any type of heart failure, HFrEF or HFpEF. There are a lot of clinically useful screening tools out there. The PHQ-2 has been identified as a very easy to use clinical screening tool, and I'll show you that in a second, but that can be used in your patients to identify those that are at higher risk of actually having depression. This is just a summary table to show us the prevalence and clinical outcomes of depression and heart failure, and this is looking at meta-analyses, but essentially, it saw that the prevalence of depression in patients with heart failure in these meta-analyses ranged in the 20 to high 20% range, and that they had links to higher mortality and secondary cardiac events and all-cause mortality at higher risk ratios. This is to show you the PHQ-2 screening tools to help identify depression in patients with heart failure. So just 2 questions. Over the last 2 weeks, how often have you been bothered by any of the following problems? And the 2 questions are, do you have little interest or pleasure in doing things, and feeling down, depressed, or hopeless? And then the patient answers not at all, several days over the last 2 weeks, more than half of the days, or nearly every day. And then these are the recommendations on scoring. And if the score is 3 or greater, major depressive disorder is likely. And there's a suggestion that you can move on to the PHQ-9, which is a more item points for screening. And I would just send patients off to be evaluated by our psychiatry colleagues if they meet that criteria so that they can get the best treatment. Just a summary of what the treatment is that's available or recommended. There's actually a fair amount of data for exercise training in patients with heart failure and depression. The HF Action trial looked at HFrEF patients that were randomized to exercise training or standard of care, and they found that the severity of depressive symptoms was significantly reduced by exercise training. That was both at 3 and 12 months. And that a longer exercise duration, so more than 90 minutes per week, associated with greater reduction in symptoms. So again, we come back to exercise being a very helpful intervention for heart failure patients. Cognitive behavioral therapy has been shown to have modest improvement in depression symptoms and quality of life, so low threshold to try to get folks in with therapists or, again, psychiatry. And PAL-HF, which was a very nice palliative care involvement in heart failure patient study, showed that the palliative care approach to advanced heart failure reduced depressive symptoms compared to usual care. So when you're taking care of patients with heart failure that are screening positive for depression or have a high risk of depression, thinking about exercise, cognitive behavioral therapy, and palliative care can all be helpful interventions. As far as medication, tricyclic antidepressants are not indicated or contraindicated in patients that have heart disease in general. And SSRIs, interestingly, even though they have a favorable safety profile in heart failure patients, so the results are pretty neutral over usual care in patients with heart failure. So really thinking about the other non-pharmacologic measures in addition, potentially. Okay, and then in the last few minutes, I'll briefly talk about renal failure. Again, a whole uh, body of literature devoted to renal failure and heart failure, but just some of the high points here. So chronic kidney disease is defined as a reduced kidney function for at least 3 months duration and evidenced by an estimated GFR less than 60. As we know, CKD and heart failure are very closely intertwined as far as pathophysiology goes. And patients that have heart failure and CKD, they have an increased risk of toxicities from the heart failure therapies, often have an impaired response to diuretics potentially. So really CKD, in addition to heart failure, makes management much more complicated. The effectiveness of many aspects of GDMT in patients with heart failure and CKD is not completely certain. The data for treatment outcomes in this population is pretty limited, and that's often because patients with pretty significant renal dysfunction end up being excluded from many of the trials. So we do have a gap in knowledge there. When we look at what some of the guidelines suggest or scientific statements suggest at this point in regards to renal failure and heart failure, the use of, again, SGLT2 inhibitors has been shown to be beneficial in slowing the decline of kidney function in patients that have HFpEF and CKD. And I've heard this described as essentially like patients with heart failure have this slow march towards chronic kidney disease. If they don't already have it when they meet you, they're on their sort of march down towards chronic kidney disease. So the earlier that we can identify that they're at risk for that and start agents such as SGLT2 inhibitors, the thought and data is starting to come in too that this will slow down the risk of decline in renal function over time. So the earlier the better. Loop diuretics should be maintained at the lowest effective dose, and really we want to maximize using MRAs and SGLT2 inhibitors to manage volume status and kind of minimize the loop diuretic as much as we can. And here this graphic is from again, the comorbidities in HFpEF, larger table that I showed you earlier. So there's some summarizing that RAS inhibitors and SGLT2s may slow progression of renal disease, and that's big star next to that. Using ARNIs if the GFR is greater than 30, and SGLT2 inhibitors if the GFR is greater than 20. And so really trying to get them on board before the patient reaches that point where they sort of become less and less an option, and to try to prevent development of that degree of renal dysfunction. So in summary, in the last couple minutes here, at least 85% of heart failure patients have greater than or equal to 2 chronic comorbid conditions that will have effects on their heart failure management and their outcomes. In general, when we think about lifestyle, exercise training has the most evidence of benefit in patients that have established heart failure. When we think about anemia, half of heart failure patients have iron deficiency, so screening and treatment with IV iron is recommended. Sleep disordered breathing is also very common in heart failure. Screening, and I would say having a very low threshold for screening and treatment with positive pressure specifically is recommended. Think about SGLT2 inhibitors as your first line agent for the treatment of hyperglycemia in patients with diabetes and heart failure, or patients with diabetes that have a risk of developing heart failure, which I would argue are probably most of them. And then optimize guideline-directed medical therapy to treat hypertension in patients with HFrEF. So there's no clear blood pressure goal there that's been established. Get it as low as tolerated essentially is how I go about that, and utilize that ability to sort of optimize the dosages of the guideline-directed medical therapy agents. And then 30% of patients with HF have depression, screen and refer. And then I would add that SGLT2 inhibitors can help decrease the march towards chronic kidney disease in patients with heart failure. So I'll put here the post-survey QR code for a couple of minutes so folks can grab that.
We have a couple of questions for you as well.
Sure.
Just a comment. I mean, it's quite incredible some of the epidemiology that you shared there, like with how, you know, prevalent some of these comorbidities are in our heart failure patients, like the 50% of iron deficiency, 30% of depression. That's so much. So the questions that are in the chat for you, the first one is, in patients that have iron deficiency, how do you decide which type of IV iron to give? And how do you go about that on the inpatient side? That's what I think is what he was getting at there.
Okay, for an admitted patient. So we actually have pathways developed. In my prior facility, we had developed a nice pathway with pharmacy. There is data on the different types of IV iron administration. So pharmacy will have a go-to. That would be the indicated IV iron. So they do need more than one administration usually. I think the ideal setup, which I think is challenging to put into place and into practice in many places, is that they get their IV iron during their admission. They may have 2 or 3 doses, and then they get follow-up as an outpatient in the clinic to ensure that their their iron stores are replete and potentially continue the IV iron. That does take collaboration at most places with renal since they are set up as an outpatient oftentimes to administer IV iron. I'm not sure, actually, I haven't encountered it yet, Michael, at Yale, if there's a nice pathway there, but usually it's easier for them to bill through renal for iron deficiency.
I've actually had to at least partner in this part of the state where I am with the hematology group in the New London area for iron infusions at their facility there. Again, trying to keep everything in house. Um, yeah, it's definitely something we can work on as a group.
I think it's not well set up at many places because it is challenging. So you can usually get a few doses in when the patient's inpatient, and I would just send the ferritin and TSAT to see if they qualify. And then most places inpatient will have a pathway you can discuss with pharmacy as to how to get them IV iron repletion. And then it's the tricky part is the follow-up as an outpatient to ensure that they're replete.
And then the second, I'll
Yeah.
go over the mechanism by which depression can cause heart failure.
So I would be probably amiss if I tried to tell you the mechanism of that off the top, but I will tell you that there is some, it's a little bit hand wavy, but I think there's some evidence that there's inflammation involved with those with depression and that inflammation can also lead to heart failure over time. But I don't think there's a clear mechanism. So there's some data that does get at that point. There are a couple nice review papers that I came across that I can share with you guys when I was putting this together, but I don't think there's a clear mechanism that's well described. I think it's similar to sort of how we think about some of those lifestyle measures, that initial pathway that I gave you for sort of the lifestyle things. Hand wavy and just in general, I think just the inflammation pathway is probably a big part of it. But if I can find those review papers, I'll share them for you.
Yeah. And probably some of it, I would imagine, too, goes into patients with depression are less likely to be able to provide, you know, great self-care and self-care habits that then can cause, some deterioration of their other health indices that then can ultimately result in heart failure down the line as well. I'm just guessing completely, but uh, thinking that possibly could play a role because could see with substance abuse or with a lack of exercise or activity and those types of things.
Yeah.
Yeah. So let's see if there's anything else here. Yeah. So this, thank you. All right.
Use the heart failure disease management clinic to give IV iron.
Yeah, I think that was
Oh,
because that John, he's one of our fellows. So I said that we're not doing it quite yet, but it should be. I mean, if you just prove the point that it's such a prevalent condition, that should be something that they're doing in our disease management clinics.
we tried to do it at my prior clinic. We did try to put together a pathway. There's billing issues with in the outpatient space that we're limiting because it does seem like we should be able to utilize that space, but I think billing for the IV iron was one thing that came into play. So I think there's just some logistical barriers there, but that would be ideal.
All right. Well, thank you everybody for joining, and thanks for Dr. Tabtabai for the great talk. I think we're off now for a week and a half, or maybe 2 weeks, and then we pick it back up at the end of May. So I hope everybody has a great couple of weeks, and the weather gets nicer for y'all. All right. Bye bye.